Well, hi, everybody. Welcome to Habitual Excellence. I'm Mark Raven, and our guest today is Dr. Denise Cardo. She is the director of the Division of Healthcare Quality Promotion, the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention, or the CDC. Dr. Cardo joined the CDC in 1993 as a medical epidemiologist in the Hospital Infections Program, later renamed the Division of Healthcare Quality Promotion. After holding several leadership positions in DHQP, she was selected as division director in 2003. So Dr. Cardo's interests include patient safety, occupational health, the prevention of healthcare-associated infections, and antimicrobial resistance. And she's recently the co-author of a New England Journal of Medicine Perspectives piece. I will link to this in the show notes. It's titled Healthcare Safety During the Pandemic and Beyond, Building a System that Ensures Resilience. So with that, Dr. Cardo, thank you for being our guest here today. How are you?
I'm doing pretty good. Thank you for having me.
Well, I'm sure as the listeners know from your introduction, there's no question why we have you here on the podcast today, because your interests are our interests as well. And it's going to be great to hear your perspectives and experiences on these fronts. The first question for you, how would you explain if somebody asks, why should we aim beyond getting just a little bit better when it comes to patient safety? Why should we be aiming for zero harm as a goal?
I always say that we should aim for perfect healthcare with no harm. Mm-hmm. That should be our goal and our commitment. But in saying this, we also need to understand that it's not a one-time approach. Mm-hmm. You have to have the commitment, but also you have to have a program and investments to really make it happen. Because we've learned, and there was a publication we did many years ago, mm-hmm. that it was for healthcare-associated infections moving towards elimination. And it was a big debate. Can we do? Can we not do? And then we decided, yes, that should be our goal. Mm-hmm. But also with understanding that to do that, we had to have programs that will include data, so we can really, data for action. Mm-hmm. So we can not just track, but target interventions and see if they are working. We need to have strategies and programs to implement everything we know that works to protect patients. At the same time, we need to have innovation and research to address the pieces that we don't know. So it's always evolving. And also we need to be prepared to respond to emerging issues. And when I say emerging issues, we may think COVID. It's not just COVID. It can be an introduction of a new technology, anything that can really change what we expect. And more than anything else, we need to have policies that you incentivize all this, and also to add transparency and accountability. Mm-hmm. And those are the pieces that we've seen in the past 10 years with healthcare-associated infections that have made a big difference. But I think I always say, as a physician, clinician, working in public health at CDC, but also as a family member and a patient, that's what I want.
Yeah, I love how you state that. Taking it beyond zero harm, but perfect healthcare. I think that's a really nice way of saying it.
Yeah, and Mark, we were concerned in the beginning that sometimes for some people who don't understand the complex of healthcare, that they probably would think that if you got to zero, you were done. Hmm. And then anything that happens after that needs to be punished. And that's not the case. You have always to be prepared it's a quality improvement. So it's an ongoing piece, and you always need to have commitment and investment in all levels.
Yeah. And I appreciate that you emphasize that focus on learning and improvement instead of punishment. One follow-up question: when you talk about tracking and looking at doing everything that we know that works, is it fair to say that the progress in reductions in harm and the adoption of the things that we know that work, is it fair to say that these are not kind of evenly adopted across the whole of American healthcare organizations?
You are correct. And that's one piece when we talk about what we do at CDC, that is really making sure that we have programs and strategies to implement what we know that works, and a way to continue to look at the data to see, are they doing everything? Mm-hmm. And if not, why not? How can we help people to do? And that's I think it's a very important piece. And sometimes people will not do because they don't know, or people will not do because they don't have the systems to do, or unfortunately sometimes because they don't want to do. But I think it's a very important piece, and that's what we learned when we worked many years ago with the PRHI, the Pittsburgh Regional Healthcare Initiative, because we thought that only 30% of some infections were preventable. And then when we showed that if you really follow everything that we had in the CDC recommendations, and if you have a way to look at the data, feedback the data, to 70% decrease. And it was the same time as Peter Pronovost, or showing the same thing. And thus we proved that it was possible. And it became the expectation. Yeah. So I think that's the important piece, that you show that if people implement what we know that works, you have very good impact. And that should be the expectation from everybody else.
Yeah, I was going to ask you and maybe you can share a little bit more about that experience of working with Ken Siegel from Value Capture, with Paul O'Neill, because in the New England Journal of Medicine piece, you and your co-authors talk about the need to learn lessons from other industries. And I think that's one thing Paul O'Neill and Ken Siegel have brought into healthcare. I'd be curious to hear some more of your history with them.
I would tell you that it was a very important turning point for me and some of my colleagues. And I think it was more a shift in the thinking process, is a cultural change more than a system change. Mm-hmm. A cultural change in what to expect and what not to tolerate. Mm-hmm. And I remember the concept of saying, yes, the Alcoa that was under Mr. Paul O'Neill had like the best program for preventing occupational injuries, but injuries were still happening. And so let's do everything so we won't see the injuries. But again, it was empowering everybody. It was really doing, it becomes, as I said, it's a cultural change. So it's what everybody expects. And then you provide the systems and the tools and everything for people to be able to do, and the data. So that was, for me and for a few other colleagues, very, very important. And even the discussion among experts that we want to prevent the preventable infections. And then it was, why just the preventable? And then it's like, no, we want to prevent all the infections. Right now, we know how to prevent some, but if we have the goal as to prevent or eliminate, it's really a much more, not just complex, because sometimes complex sounds like difficult, complex in a way that is really always learning, always improving. And that's when I say is a cultural change, and is a cultural change in expectations. Because that's what we're able to change in the country. People would say, oh, you always get an infection. You expect that. So expectations changed. Mm-hmm. And I would say that the engagement of patient advocates and the work we had, we still have with them is so important, has been so important. Because it's like, why you would accept that that case will be infected, or that there is, so it's a change in expectations. But as I said, but always remembering there is no magic bullet, there is no one time fits all. But I always say, as a federal agency, it's very important for us to define standards, expectations, and work with all the partners to move in that direction. Because sometimes the how to move may be different, but we all need to achieve a similar goal and measure that in a similar way.
So how would you describe the role of the CDC in working with healthcare organizations, whether it's hospitals, health systems, clinics, different settings? What's the role of the CDC in partnering with them? Has that role evolved or changed over, let's say, the past 10 or 20 years?
So the mission of CDC overall is to protect lives and improve health of Americans, of people in the United States and abroad. And it's data-driven, evidence-based approach. So the way I see that the way we have changed in terms of healthcare, CDC traditionally would work more with public health partners, okay? And with our program, we are like working more with the healthcare partners. In the beginning, more with the hospitals. But it became very clear, especially when we really embrace the concept of elimination, when we start working with also other federal agencies, that public health and healthcare, if we don't work together, not just at the federal level only or the organizations, but locally, we won't get to the goal that we have. So we work very, very closely with experts in the healthcare systems themselves, organizations, private partners, and also the ones who pay for care. And one piece that is very important, I always say, is learning not just from what we publish, but learning also for what is happening and talking. So we also convene a lot partners to better define what is the best way for them to approach that problem. Before, it was just hospitals. Now, when we talk about preventing infections, improving antibiotic use, preventing all harms, it's hospitals, nursing homes, urgent care, ambulatory care, everything. And each group is different. So we really work a lot with them. And I always say expectations are the same, but we have to tailor and target to what they have. And also one piece that I think it's important that we bring to the table is how to develop standards, and I said also expectations, especially with data that can be used. And in the case of healthcare-associated infections, we use the National Healthcare Safety Network plus other data sources, and working with the healthcare system to see how can they use the data, and what other tools that we can provide to be helpful to them. So we work with them for data issues, implementation, and as I said, innovation. We also fund programs in all states, and those programs have to work with the hospital associations, with also the hospitals or nursing homes. And so that's what we do. And for the innovation, we also fund and support not just academic centers, but also healthcare systems to see how can we make things better. And then we can show to the others how to improve in the same way. My final thing is in DHQP, in my division, we have a lot of expertise, and we have many of the clinicians still work. And that's a critical piece, because I want people to be also taking care of patients. So we are not just being in a world that is not the real one.
Sure.
So we do that also because I think it's very, very important. But I always say that we can define expectations, standards, data, provide the data. If we don't work with partners that will make things happen, it doesn't happen.
Yeah.
So that's kind of the way we do in terms of working with healthcare. And I think with COVID became very clear that connection, healthcare, public health, if it doesn't exist, it's very hard to control anything.
And we'll come back to that in a moment, talking about some of the impact of the COVID pandemic on patient safety. But I wanted to ask, first, Dr. Cardo, you talk about collaborating with other U.S. federal agencies and health systems of all kinds, and the CDC, like you said, the focus is on the health of Americans. But I think the CDC is viewed as a leader in other countries. I think people look to the CDCs for expertise and guidance. At the same time, I'm wondering if there are collaborations with similar organizations from other countries of the work that they're doing to improve patient safety. I'm curious how much sharing is happening in all directions across borders.
Thank you. So I can have an opportunity to talk about this. Mm-hmm. As I said, we work a lot with federal agencies. I think I will give examples, especially with CMS, but also with ARC. And so we really work with sister agencies. So it's not that we just align. We really work together to accelerate progress. And as I think it's a very, very important piece is really looking first to avoid duplication, because we don't want to increase burden for health care or for anybody. And to move, as I said, towards transparency and accountability. Our work with CMS is critical for the alignment of practices, programs, and policies, not just because of the policies becoming an incentive for the practices, the evidence-based practices, but also because of the programs. CMS has programs like the Quality Improvement Organization. We have programs in the state. We make them work together. And we also share the data from the NHSN in such a way that they can all use to really move towards improvement. And Mark, we're always looking and okay, what is not happening? What this specific group is not improving? How can we improve? So it's a work really together. It's ongoing work, and we do have the same goal. ARC, the same thing, because some of the research questions that ARC will address are questions that came from us, analyzing and identifying gaps. So then we can use that for the implementation. So we really, the three agencies, I know sometimes people think, oh, she's just talking. No, we really work very closely on a daily basis. You mentioned international collaborations. It's very, very important. We work with a lot of colleagues from outside US. And we work in a formal way, informal way. There's so much that we don't know. Mark, when we talk about antibiotic resistance, oh my God, so much we don't know. And then we learn, for example, in England, they're having an outbreak that it was a very bad bacteria, resistant bacteria, and it could be related to the faucets. So, and then end up that we're having a similar thing also in one place here in the United States. So we convene and we start working together to see what first, how can we understand what is going on? Second, what are the innovations that can be done? So we work all the time. There are some outbreaks because now with everything being connected, so some outbreaks related to devices that happen not just in the US, also happen in other places. And we tell each other and we really work a lot to see, not just to share knowledge, but solutions.
Yeah.
And we convene meetings together, like we at CDC with University of Geneva, WHO, ECDC. We do every 2 years think tank meeting, not just to address the known, but the unknown, how we move forward with even more aggressive impact. And so it's an ongoing thing. And we also work with WHO. We fund WHO, and we have people there. So we really take that collaboration extremely serious, because if we don't, we will not move towards the goal that we have. That is really always improving to become the perfect healthcare with no harms.
Well, it's great to hear. And, there are shared goals. Unfortunately, there is a shared problem. The scale of patient harm, on a per capita basis is very similar in other Western countries, at least from the data I've seen.
Yeah. And it's interesting because the connection that we have with CMS that made possible to really embrace transparency and accountability. So for healthcare associated infections, especially for the hospitals, you can see what is going on in your hospital using the CDC data that CMS posts. And but at the same time, there is a way to align payment and incentives to what is happening. And that's unique. And most countries are not there yet. Yeah. And they even get very surprised when we say that we're doing this. And I think it's, in other things, we're behind. So it's a balance.
Yeah. So the last thing I wanted to cover here is touching on things that you and your co-authors wrote about in the piece I mentioned earlier of, this period of the pandemic, what seems to be data that shows a reverse of the trend of some progress of seeing in the last 2 years an increase in falls, hospital-acquired infections, pressure ulcers, other things like that in hospitals and skilled nursing facilities. How would you summarize the causes? How did the COVID era change how care was being delivered in a way that led to this increase in harm?
I think what COVID has shown to us is that our healthcare system is not resilient. And also there are other pieces that we knew, and COVID made it even more clear to all of us, that one healthcare facility cannot be in isolation. You may have a hospital with the best program for preventing infections and everything. Patients move. If you don't have a system around you, facilities around you that also have good programs, you're never going to move in the direction you need. And COVID made that very, very clear. We're already seeing that with antibiotic resistance, but with COVID, it was just the movement between nursing homes, hospitals, community. So that piece I think is very, very important. You cannot work in isolation. And also you need to have not just a good healthcare system, but a good public health, and they need to work together. So I think this is extremely important. The other piece that you mentioned, it was so first in the beginning when we started seeing the problem with COVID. This was in March. We discussed with CMS, and we thought that probably would be a burden for the hospitals to have to report the infections, the healthcare associated infections, and so it became a voluntary process. They were not related to the payment. Despite that, the hospitals continue to report, but it showed to us that they're seeing value in what they are reporting and using that information. So when we look at the data and we start seeing like things reversing, so all the great progress, 50 to 70% decrease of CLABSI, decreases of UTI, everything, the opposite. Mm-hmm. And so there are, we know the patients were different, mm-hmm. they are more severe, but this is, I always say, it's not the excuse for us not to prevent. Mm-hmm. But it also shows that all the programs are not sustainable. And we need to really think, there are so many gaps. It's so easy to break the systems. And it's not that people didn't want to intervene, to follow the recommendations. It's just there was like no gowns or a lot of system mm-hmm. issues. And I think this is really showing how much we need to rethink. Another piece that is very important that COVID showed is the disparities mm-hmm. and issues with equity. And the access to care, not just is not the same, access to quality care mm-hmm. varies. Right. That also it needs to be addressed. And the healthcare force, the healthcare workforce, people are tired, mm-hmm. exhausted, and facing not just many issues at work, but then concerned that if they get an infection, they will bring home. Mm-hmm. And always, so we need also to rethink about how to better structure that in terms of number of healthcare providers. I'm not just talking about clinicians, I'm talking about everybody. Right. That probably we really need. So I don't think it's just when we think about systems, it's systems with people. Mm-hmm. And I do think we need to relook at that. We learn, for example, that we all know that the ones who work in healthcare don't have time for training. So now at CDC, we developed and launched the Project First Line to train the first line people, not just some, and in a way that are very easy tools and videos. And what also we learn is you don't not just tell people the what they need to do. You explain the why. Yes. Because when you explain the why, then you figure out a way. So explaining why they are doing, the importance of that to protect the patients and themselves really is critical because they start to incorporate that in everything they do. Mm-hmm. So we're also changing the way we work with healthcare. So it's not just healthcare needs to change. We all need to change in terms of the federal agencies and associations and the payers. But I feel that we don't have the solution. But the fact that we all acknowledging that, and the fact that you invited me to even talk, I think is critical, because I think it's a commitment to not just fix the system, but do much, much better in moving forward.
So maybe one final question for you on that theme of moving forward. In the article, you and your co-authors use phrases, I think, of what you would want to see as an ideal. So two phrases I'd like to hear your thoughts on. The one you already used in this interview, a sufficiently resilient safety culture and infrastructure. And then the second thing you mentioned is an unflagging commitment to safety. So what would be some evidence that you would expect to see of that becoming the case in American healthcare, both that safety culture that's resilient and having an unflagging commitment to safety? How do we know if that's happening?
I think the first piece is when we sit together to fix it and we don't come up with excuses. And that's what I say, no blaming. Nobody did this. We all suffered the whole problem we faced. So I see it's really when sit down and for fixing the problem. I see that things are better when we have less criticism about the data, if it's needed or not, but the use of the data for action. And I think this is a critical piece. For me, having people sitting to really fix without blaming and without excuses is a critical first step to see that we're moving towards a solution. And it's going to be many, many, many options. The great thing about the article is the number of people who reach out to us to be part of the solution. Like, okay, we want to share with you what we are facing and potential ways in moving forward. Mm-hmm. I thought it was fantastic because initially I thought, okay, they are going to say, no, you're wrong. No, people are like, no, let's. So I see that's a critical piece. And so now we need to start moving forward with concrete steps. We need to move forward, not just in terms of the healthcare-associated infections and patient safety. I think we also need to move forward with better preparedness of our healthcare system. I think we have enough information and data that we look and see there are parts of the country they are more prepared than other parts. There are specific institutions that are more prepared. They are, and when I say prepare, is even having the PPE is, I'm not saying exercises. Mm-hmm. At CDC, the commitment, and I know also from CMS and ARC, that we want to put those things at the table and start moving forward. And so I will be happy if we really use that as the opportunity, as I said, as the enzyme to change the system. It's not going to be easy, sure, but we have to start.
Well, thank you for sort of laying out that challenge and the ideal condition we're working toward. I appreciate your thoughts on it not being easy, that there are no silver bullets, but more collaboration, more learning, more action, less blaming. Those are things moving us in the right direction.
And one piece I learned, the things that work well and things that did not work well, and is trust is very important. So I think we working together, and I think that's one piece with CMS, CDC, is the trust. We doesn't mean you have to agree, but at least you know that the intention, that you trust in the goal, in the commitment. There's a trust on that. So I think this is very important. The other important piece is clear roles and responsibilities. I can anticipate that many groups will say, no, now we are going to do this. I'm like, no, there's space for everybody. Let's not try to destroy what is there. Let's try to build upon what we have, but with really the goal of doing better. So I think it's like improving what we have is a good way to start what we do. And like I said, roles and responsibilities, and avoiding parallel actions. I think the more we can be really focused, I think the better. We will define very concrete targets for us to accomplish soon. And I'll be happy in the future to even come and say, are we accomplishing what we need to accomplish or not? And if not, what we're doing to move in that direction.
That's great. Well, thank you so much, Dr. Cardo. Again, our guest today has been Dr. Denise Cardo from the CDC, the Centers for Disease Control and Prevention. Really did enjoy that article. I'll put, again, there's a link in the show notes to that. We hope people will read that article and think about what that means for them and their patients and their organization. So again, Dr. Cardo, thank you so much for being a guest here today.
Thank you so much, Mark, for having me.